Bun găsit la emisiunea Știință și Cunoaștere. Continuăm prezentarea celor mai devastatoare boli ale secolului 21 cu ajutorul invitatului special, profesorul Michael Fossel. Astăzi vom vorbi despre Parkinson. Cele 4 grupe de maladii asociate cu îmbătrânirea sunt Accidentul Vascular Cerebral, despre care am vorbit în prima emisiune, Alzheimer, despre care am vorbit în a doua emisiune, Parkinson, despre care vom vorbi în minutele următoare, și Ateroscleroza, despre care vom vorbi data viitoare. Ca un prolog la ceea ce vom discuta în minutele următoare, citez o scurtă prezentare de pe Wikipedia care conturează bazele de înțelegere a maladiei Parkinson. Boala Parkinson este o boală degenerativă ce survine în urma distrugerii lente și progresive a neuronilor. Întrucât zona afectată joacă un rol important în controlul mișcărilor, pacienții prezintă gesturi rigide, sacadate și incontrolabile, tremur și instabilitate posturală. Tulburările legate de boala Parkinson apar cel mai adesea între 50 și 70 de ani. Vârsta medie de apariție a bolii este de 57 de ani. La început, simptomele pot fi confundate cu procesul normal de îmbătrânire, dar pe măsura agravării acestora, diagnosticul devine evident. În momentul manifestării primelor simptome, se crede că între 60% și 80% din celulele din zona de control a activităților motorii sunt deja distruse. Boala Parkinson are o evoluție progresivă, iar semnele și simptomele se acumulează în timp. Deși această afecțiune este potențial invalidantă, ea evoluează lent, astfel încât majoritatea pacienților beneficiază de numeroși ani de viață activă după stabilirea diagnosticului. Mai mult, spre deosebire de alte afecțiuni neurologice grave, boala Parkinson este tratabilă. Tratamentul este medicamentos și chirurgical, dar poate consta și în implantarea unui dispozitiv pentru stimularea creierului. La scară mondială, boala este diagnosticată la 300.000 de persoane în fiecare an. Incidența și prevalența bolii cresc odată cu vârsta. Boala Parkinson afectează 1% din persoanele cu vârsta peste 65 de ani. Rare ori, boala survine în copilărie sau adolescență. Incidența bolii este de 1,5 ori mai mare la bărbați decât la femei. Cu siguranță, medicina viitorului va rezolva problema acestei boli și sunt optimist. Eu cred că vom asista la surpriză uimitoare, iar acum vă invit să vizionați partea a treia din interviul cu profesorul Michael Fossel, înregistrat la data de 21 iunie 2017, în care vom vorbi detaliat despre boala Parkinson. Dear Professor Michael Fossel, welcome back to our TV program Science and Knowledge in Romania for part 3 of this new mini-series of interviews via Skype.
Again, mulțumesc.
Mulțumesc și eu de asemenea. It's an amazing opportunity to discuss with you highly important information about the most devastating 4 age-related diseases. And I had chosen a specific order of these episodes due to the fact some issues interconnect with what you already told us in the previous episodes, so the viewers can relate to them by accessing the links on my YouTube account. The third part of these episodes is dedicated to Parkinson disease. Let me enhance that Romania is also on top with 70,000 patients out of 20 million population. Is the situation similar in US?
Very much so. And in the last few decades, we have always realized that Alzheimer's disease and Parkinson's disease, we've thought of them as two separate diseases, but we've always realized there was a slight overlap. And I think that that's become more obvious and more accepted in the past 10 years. It is not that there is Alzheimer's and Parkinson's and they're totally separate. There are these interesting links, and I think we've begun to understand the underlying cause of that overlap. Classically, Alzheimer's disease was a cognitive disease, and Parkinson's disease was a motor disease. That is, here I couldn't move well, here I couldn't think well. But we know that in Alzheimer's disease, some of these patients can't move very well, and some of these patients with Parkinson's can't think very well. There's a dementia component of it. I think it's even more true than that. There's a lot of overlap, as I say, not just in the symptoms of these patients and how they present, but at the underlying level, if we look at the function of glial cells, what you find that is in both cases, the glial cells have become dysfunctional. And the outcome for that in Alzheimer's disease is that you get beta amyloid, tau proteins, and other changes. The outcome for that in Parkinson's disease is that you see these alpha-synuclein proteins being deposited in places like the substantia nigra. So the actual proteins that are deposited, the hallmarks of this disease and the location of the disease is somewhat different. But again, there's some overlap. And I think the reason for this overlap is dysfunction of glial cells. The implication from our perspective is that we should not only be able to prevent and cure Alzheimer's disease, but we should be able to do the same thing for Parkinson's disease.
If we wish to present a definition for our viewers, what would be a definition of Parkinson's disease?
Well, classically, it's a disease of motor function. So, example, I will find that I might have a Parkinsonian tremor in my hand. Or I may find that as I walk, most of us, if I walk across the room, absolutely not thinking about it, my hands will move, my arms will swing a little bit. That's normal human behavior. Where in some Parkinson's patients, what they'll do is as they walk across the room, their arms will remain just hanging down. There's no swinging motion. The other thing you'll see is that sometimes Parkinson's patients, particularly advanced Parkinson's patients, will have a hard time initiating a behavior. So I'll be standing up and I'm trying to walk across the room and I've got Parkinson's, but I can't seem to get going. Once I get going, my arms and legs may, or at least my legs, may move fine. But it's that initiation of motion. I sometimes think of this with a computer analogy. Many of us have used macros. Macros are small bits of programming that let us do things repeatedly. So I may have a macro, for example, if I'm searching a document and I want to replace A with B, I want to do a replacement, I essentially have a little macro. I go in and say, find all cases of A and replace them with all cases of B. That's a macro. Well, your brain has macros. One of those macros is when I walk across the room, my arms swing. You don't think about it. It's automatic. You sort of hit the button that says walk, and your brain puts in the little macro that says, and swing your arms too as you move. But in Parkinson's disease, these motor macros fail. It's as though you were erasing them. So you can try to reprogram, relearn behaviors. For example, Parkinson's patients can't get that macro going that says start walking, but what they find is that if they lean forward and begin to lose their balance, they automatically will start walking. So they've substituted another macro for the one that doesn't work. But again, what's going on in Parkinson's disease is this loss of automatic behaviors, things that are unconscious. We never think of it. You don't think, don't tremor. You just don't tremor. Or we have a minimal tremor. You don't think walk with your arms and legs. You just do it. But those automatic functions tend to get lost. So that's the basis of Parkinson's. Now, as it turns out, it's more than that, because you find their autonomic dysfunctions. Their GI system, the gastrointestinal system, will show some disturbances. Their dreams may show disturbances. Their ability to think or remember may be impaired as well. Again, making you think of Alzheimer's disease. So it's not as simple. It's a motor disease. And yet, that's the classic description of it.
How can one be aware of the symptoms? What are the main symptoms of Parkinson's disease for someone who is not knowing what is happening before going to his doctor?
Well, often you're not. And again, this reminds me of Alzheimer's disease. So I had a neighbor of mine, and I noticed that as he walked, his arms didn't swing. Less and less, over a year period, less and less. And his wife noticed, quote, something wrong about his movement. That was it. She couldn't put her fingers on it because you don't tend to notice the arms swinging as you move. But she knew something didn't seem right. But to me, looking at him, I could see, I didn't see him often, but when I saw him, I looked at him do this, and I thought, this is early Parkinson's. So I sent him to a neurologist, and he was diagnosed. But he himself was not aware of this. It was right past him. His wife picked up on something she couldn't define. I saw it and was used to it clinically, professionally, and recognized it as Parkinson's. But I think that that's often true of patients. The spouse or friend, a family member will look and think, something's wrong. The patient may not be aware of it. Patients who are aware of it tend to notice things that stick out, like a little Parkinsonian tremor or difficulty walking. But it has to sometimes get fairly obvious before they either notice it or are willing to acknowledge it.
About these hand tremors, you triggered some memories from my high school years about 32 years ago. And at that age, around 20 years old, I was beginning using exaggerated coffee quantities, about half a liter or more per day, every day, for almost 6 months. And I was believing that by using large amount of coffee, I could stay awake at the classes, which were in the evening, while all day I had a full-time morning job until late afternoon. But it didn't help me stay awake in the evening. On the contrary, after 6 months, I began to see my hands having tremors, and I could not do my work. I could not handle Letcon to blend components on an electric motherboard, and this effect scared me. And then I stopped using coffee, and I needed another 6 months to reverse the effects. In the beginning it was very difficult because I felt very fatigued, and finally I got better and completely recovered. So that was a life lesson for me. From that moment on, I'm only using coffee as a medicine in small quantities.
Understand? Let me say about tremors or trembles. Technically, everybody has them. If I look at my hand and I look at anybody's hand closely enough, you'll find there's a little microscopic tremor. The question is, do you notice it, and does it affect what you do? But nobody is absolutely steady most of the time. They almost always have some degree, even if it's impossible to see it. If you measure very carefully, you'll find there's a little bit of tremor. And as an engineer, you'll appreciate it. It has to do with feedback. And what happens is, I'm trying to keep my hands steady, and they're a little drift, and anytime there's a little drift, my body will try to pull it back to where it was. So it's a continual back and forth motion. And if the system is designed well, whether it's a mechanical system or computer system or a human system, that tremor is negligible. That is, those tremors are so small and the feedback is so exact that you don't see a tremor. But anything that interferes with that increases or decreases the timing of that feedback, will end up with a tremor. So for example, coffee. Epinephrine, adrenaline. Any of us who are frightened have noticed that afterwards you may be a little tremulous. Well, naturally, you've just disrupted the feedback loop. The timing is gone because your body is so full of adrenaline, your heart's racing, that the feedback now is wrong. The timing's off. It's like taking a computer and replacing it with a clock that's 100-fold too slow or too fast. The computer can't function well because the timing mechanisms are gone. This happens in people too. So one of the things that fails in Parkinsonian patients is that the timing loop becomes disrupted. And so, yes, you and I are always tremoring, but the tremor is so microscopic that you can't see it, may not notice it. But in Parkinson's patients, that feedback mechanism still works. It's just it's a little off, it's a little slow, and so it's tremoring rather than doing it in a microscopic way.
How can a patient detect the most early symptoms of Parkinson in order to have the best chance to stop it or slow it down maximum as possible?
Again, what you're looking for is, usually you're looking for disruptions in motor behavior, but you do see changes in dreaming or sleep behavior. You see disruptions of gastrointestinal tract, but that can be caused by any number of things. I mean, some of us have bad dreams or don't sleep well for lots of reasons. Some of us have gastrointestinal problems for lots of reasons. So it's not so easy. It takes a suspicion, and usually what brings somebody in is a motor problem, difficulty walking, or as I say, tremor, and it's usually picked up by a family member or friend who brings it to the attention of the patient who comes in to see somebody. But the point you raised about getting seen is a good one, because let me distinguish Parkinson's disease from Alzheimer's disease. Alzheimer's disease is uniformly fatal, and there is no treatment for it. There's no pharmaceutical treatment for it anywhere in the world that works. But Parkinson's is a little different. People can end up with Parkinson's disease for decades. It can progress or seem to stop. There are a number of drugs, both in current use and experimental use, that look like they may be effective. So in Alzheimer's disease, you could say, well, whether you get treated or not, you still got a problem. In Parkinson's disease, treatment can be important, because there's a pretty good chance that you can at least make the symptoms better and maybe do something about your long-term problems with it. So yes, it matters.
What are the medical diagnosis tools for the most early onset of Parkinson?
The typical tool is the neurologist who simply starts by interviewing the patient, what happened, what brought you in, and then it progresses to a detailed neurologic exam looking at things like tremor and motor function. And then it may progress to some electrophysiologic studies. It may progress to some scans, for example, an MRI trying to look at the substantia nigra. So there are any number of things that are used, but essentially, like Alzheimer's disease, Parkinson's starts as a clinical diagnosis. It starts with somebody saying, this doesn't look right, and I think I know what it is. It's Parkinson's or it's Alzheimer's.
How does this disease evolve with the passage of time, and what are the symptoms in the following stages?
Well, you know, with Parkinson's disease, again, classically what you're looking at is continual problems with motor function. So they may start with a slight tremor, but they end up not being able to hold a glass or drink. Or they may start with a slight inability to get started and end up being unable to move at all. So you can see the motor dysfunction. But the other things that happen is you do see sometimes, or in many cases, progressive cognitive problems too. So they start with these simple motor problems, progress to more advanced motor problems, but they're also beginning to show problems with memory or cognition, ability to think. And the same is true of some of the other associated symptoms like gastrointestinal disruptions or sleep function. So it often becomes more widespread. But from my perspective, it seems like the course is a little less predictable than with Alzheimer's disease. You know, you see some people get much worse very quickly and some people very slowly. That happens in Alzheimer's disease too. But I think that it's a little less predictable as I look at some of the Parkinson's patients than the Alzheimer's patients. On the other hand, I confess that, you know, it's been a long time since I've taught neurology courses, and it's not my area. I'll stick with Alzheimer's.
There is a saying, one big bad thing never arrives alone. Always there are more. Please tell us what other diseases or complications might appear while a patient is already suffering Parkinson's disease.
I think you're right. You know, we've all noticed in family members, for example, you know, you've got your great aunt who is doing absolutely fine, living by herself, no problems, and then she tripped and broke her leg. And the next thing you know, she's got a pneumonia. And then she developed Alzheimer's disease. And these things seem to, it's like falling down a cliff. You're starting an avalanche. You know, first it's just one little rock, and then it's two big rocks. The next thing you know, the whole cliff is falling down. And I think that we've all seen that happen with patients that we've known or family members we've known who were fine. Some little thing happened, a bigger thing happened, and then everything seemed to go wrong.
What could be the most important causes of Parkinson's disease in your opinion?
From my perspective, all age-related diseases, all of them, Alzheimer's, Parkinson's, arterial disease, osteoarthritis, osteoporosis, immune aging, skin aging, all of these things have a common underlying factor, a common denominator, and that is changes in pattern of gene expression within the cells that cause these diseases. That is cell aging, cell senescence, changes in telomere length, changes in gene expression. So they're all linked. So, example, you know, we know that one of the major predictive factors for Alzheimer's is simply your age. The older you are, the more likely you are to have it. And it's actually a better predictor than genes. Just age alone is a pretty good predictor for many of these things. But the same is true of osteoarthritis. Very few patients get osteoarthritis to age 20. Very few patients get Alzheimer's to age 20. The older you are, the more likely to have either one or both. So what I'm saying is that, one, the underlying causes of these things have a common factor, cell aging. The other, though, is that age alone is going to be predictive. So if you have Alzheimer's, that already means you're more likely to have other age-related diseases, like arterial disease. So that's one part of this. They're all linked in some way. But the other is sort of what I think you're alluding to, which is the stress of an event. If I think, again, we've all known family members or relatives or friends who have been an elderly couple. Maybe they've been married for 50 years, and one of the couple dies. Now, the odds of that other couple dying in the next year are enormous. You know, if you're 70 years old and your wife of 50 years died, you're more likely to die in the next 12 months. There's an enormous stress involved in these things. But the same is true of diseases, too. So if I end up with a heart attack, that's an enormous stress. That's going to increase the stress in my brain for Alzheimer's or in my joints. It's going to change a lot of the way my body moves, acts, thinks, you know, functions. So anytime you have a major disease, you're already both saying there are other diseases that are related to the fact I'm getting this. I'm getting old, so everything's more likely. But you're also saying you've just had a major event happen. You're diagnosed with Alzheimer's disease. That's a huge stress. Your blood pressure goes up. You're more likely to have a heart attack. So your immune system doesn't work well. All of these things tend to play. So there are two major reasons why that happens, that avalanche of problems. One is they're all linked. You're getting older. The other is every time something goes wrong, it stresses another system.
Why this disease is presently manifesting in a more younger groups of population, same as Alzheimer. This is interesting. In the past was somewhere as 65 years old. Now we have patients of Parkinson at 50 years old, and that is very disturbing.
Well, I'd have to give the same answer I gave before, which is the quick part of this is I don't know. And there are a number of answers that come to mind, but they fall into two categories. One is diagnostic issues. That is, before, we may not have been as good at diagnosing Parkinson's or Alzheimer's as we are now. My guess is that 50 years ago, we just didn't have the tools and the common medical knowledge and training to pick those things up sometimes. That could be. And I suspect that's a part of it, but it's hard to prove that. And the other has to do with increasing actual risk. So in the case, again, of Alzheimer's disease or Parkinson's disease, anything that increases your risk of head injury will increase your risk of those diseases. Same would be true of certain infections. If I can increase the risk of a viral infection that gets into my brain or otherwise stresses my immune system, I may be increasing my risk of Alzheimer's or Parkinson's. But I don't know that either of those are true, and I don't know that we're not missing something else. I suspect they're both true. That is, one, we're picking up cases we didn't know about before. At younger ages, we're better at it. And two, there may be other things going on in the diet, in the environment, in how we act culturally that changes some of this.
Many of Parkinson's disease patients might experience dementia in the evolution of this disease. Why is that?
Well, again, it's because they share underlying risk factors. I sometimes divide dementias into two broad categories. Those that are caused by the brain itself and those that are caused by the blood vessels. So the latter are sometimes called vascular dementias in general. But if we're looking at dementias in general, you have Alzheimer's dementia, you have Parkinson's dementia, frontotemporal dementia, Lewy body dementia. There are all sorts of categories of I think of it as minor dementias, but they're not minor to the people who have them. But most people think of Alzheimer's as dementia. But there are many kind of dementias. Again, Parkinson's comes to mind, but it goes well on beyond that. So all of these, though, still are linked at an underlying level to changes in cell function. For all of the dementias, except for the vascular dementias, it's the glial cells that seem to be the trigger for this, or the best point of intervention. For the vascular dementia, it's the endothelial cells that line those blood vessels that are responsible for it. And we can treat both the same way, but we're treating different sets of cells. The outcome is the same either way. Dementia is a dementia. You can have all sorts of different symptoms in a dementia, but either way, it's not something we like, and either way, it tends to take away your brain, your mind, your soul.
Let's analyze the scenario and say that a patient already is in an early stage of Parkinson, but he also has stroke or atherosclerosis. What would be the complications in this case?
The same question you asked about Alzheimer's and a stroke too, and the answer pretty much is the same, which is, the stroke itself is a major problem because there's very little we can do about it, particularly once it's past its initial phase of a few hours or a day or two. So the stroke itself is a major problem by itself, but it's also going to increase the stress to the body. So if I've had a stroke, my expectation clinically is that I'm going to see an accelerated downturn in the Parkinson's disease or Alzheimer's disease or other dementias. That is, just the stress itself will, in many cases, accelerate the rate of disease.
Let's take another scenario, and the Parkinson patient is also experiencing advanced and severe depression. What would be the most important issue in ameliorating his life?
Well, let me say this, that Parkinson's disease or Alzheimer's disease, either one of them, is a depressing disease. There are very few patients who suddenly perk up because they've been diagnosed with either one. You'd wonder about their sanity in the first place. by the nature of things, if I've been diagnosed with Parkinson's or Alzheimer's disease, I find that depressing. So that's just a psychological view of it. But let me step back a second and ask about the anatomic changes or the cell changes. There's some interesting data that suggests that in many cases, depression, particularly in aged populations, may again be related to either vascular issues, that is, the blood supply is not as good, or the glial cell function. In either case, you're looking at cell senescence, changes in pattern of gene expression. So if I'm at risk of Alzheimer's disease, I'm also at risk of osteoporosis, not because they have the same system, but because in both cases I'm older. If I'm at risk of Parkinson's disease, I may be at increased risk of depression, not because it's exactly the same cause, but because in both cases my brain is older and the aging of those cells may cause either one or both. So it's not unusual that you see depression in patients with Parkinson's disease, for example, because it's the depressing thing to have. I can't move the way I'm used to, but also because in both cases your brain is older and that increases your risk of both of those things happening. So it's both psychological and genetic, both.
Please feel free to extend your talks and use the necessary amount of time that is needed to complete the answers.
Well, in this case, let me just say again that you can be depressed because the conditions in your life are depressing. And you can be depressed because you have an actual pathology of the brain. So it could be psychological or it could be actually cellular. Either way, depression is depression. If I've been going out with some woman for 5 years and she turns to me one day and said, "I've had it, I'm leaving you, goodbye," and the same day my boss fires me from my job and my dog dies, that's depressing. And it has nothing to do with the fact that my brain wasn't functioning. Those are just depressing events. And those are psychological. In the same sense, if you diagnose me with Parkinson's, that's a depressing event, independent of how my cells are functioning. But cells also dysfunction because I'm getting older, and that increases my risk for depression as well as Parkinson's. So I expect there to be links between Parkinson's and depression on two counts, psychological and cellular, both normal. Not pleasant, but normal.
Yes. On the internet, I found out that there are some environmental risk factors like pesticides, carbon monoxide intoxications, or neuroleptics like phenothiazine. Can you explain what does these factors in the brain cells?
Well, there are a couple of possibilities on this, and both are true. And so in the acute case, for example, say I'm exposed to an organophosphate insecticide. Acutely, it'll change the way my neurons talk to one another. It'll change synaptic function, and that can have all sorts of consequences. It also, not only are there acute consequences, but it increases the risk of damage to the neurons, and it's going to accelerate the aging of the glial cells, the changes in gene expression that happen as we get older. So this is true of a lot of these possible toxic exposures. Many of them will have acute consequences, like organophosphate poisoning, where I may find out I get spasms, for example. I had that happen to me once, actually. But there are also longer-term consequences directly in terms of their impact on neurons, and then longer-term consequences in terms of cell senescence and changes in gene expression throughout the rest of the brain. So yes, a lot of these toxic exposures will increase my risk, for example, of Alzheimer's disease or Parkinson's disease, which is classic. Pretty understandable, makes sense.
Please explain how other diseases increase the risk of Parkinson, like hydrocephalus, cranial tumors, subdural hematoma, Wilson's disease, and idiopathic degenerative disorders.
Well, let me say that some of these things don't sort of increase, some of them do, but some of them don't increase the risk of Parkinson's so much as they're correlated with it. So I could have an underlying genetic defect that may result in me getting an increased risk of Parkinson's, but also a risk of hydrocephalus, for example. And it may be that the hydrocephalus didn't actually cause Parkinson's, but something else caused both. That can happen. It's a common genetic defect that has two different outcomes. Both occur. At the same time, it's also true that anything that damages the brain, for example, hydrocephalus, can have direct effect on the function of the neurons and the glial cells in the brain. So if I had hydrocephalus and increased pressure in my brain, that can lower the function of the glial cells and cause some long-term changes in gene expression that results in me having Parkinson's disease. That could be. So there are any number of reasons these things can happen. Some of them are not actual causal, they're just correlations caused by something else that's going on with both. Or in many cases, anything that injures the brain or causes a problem with the brain, like Wilson's disease, an abnormal copper metabolism, may result in lots of other damage throughout the neurons and the glial cells in the brain, and increase my risk of Parkinson's or Alzheimer's or other forms of dementia or other neurological problems.
Are there any known genetic factors causing?
Yeah, I mean, almost no matter what you ask at that point, that cause or yes.
Yes, you are correct.
Genetic factors are related to everything. Absolutely.
I must delete that word. It doesn't cause.
They're related to everything.
Gene doesn't cause anything. They are correlated. About the genetic factors favoring Parkinson.
Yes, but again, I haven't paid as much attention to them. I've been pretty much focused on Alzheimer's disease. But yes, there are, and again, in almost all cases, the genetic risk factors don't cause Parkinson's, but they increase your risk of it or decrease your risk of it. Again, back to the Alzheimer's example, if I have an ApoE4 protein, two of them, my risk of Alzheimer's goes up. But some people with both of those don't get Alzheimer's, and some people with neither of them get Alzheimer's. If I have two ApoE2 genes, my risk of Alzheimer's goes down. And yet some people with two ApoE2 get Alzheimer's. And some people with Alzheimer's, don't have it. Some do. It just, any of these genetic factors, Alzheimer's or Parkinson's disease, are not absolute. Well, almost never. The genetic factors we know about don't cause it, but they're related somehow.
What kind of medical treatments exists on the present moment in order to treat this disease? For example, surgery, anticholinergic drugs, selegiline, and neuroelectrostimulation.
You kind of listed them right there. I think of about four of them that come to mind right away. The classic one is pharmacologic, and there you're starting with L-DOPA and then going on to various other drugs that are either related to it or in some cases try to replace it. So that's sort of the classic treatment. And then in the last 20, 30 years, you begin to see a number of things coming online, starting with surgical approaches. So the system that controls that feedback that I was talking about in muscle motor control involves the substantia nigra, but it also involves other nuclei as well. And if the substantia nigra is damaged, the question is, what if I then damage some of the other nuclei so you don't have an imbalance? And that sort of approach has been tried, and occasionally with some promising results, but it certainly isn't a panacea. The next thought would be, as you mentioned, electrophysiologic stimulation. So if the substantia nigra seems to be damaged, what happens if I put in stimulation to increase the amount of output from those cells that remain? And again, tantalizing results, and sometimes remarkable, but not a panacea. A third general approach that I've seen is stem cell work, or whole cell organ transplantation in the case of some animals. But the idea here would be, I've lost part of my neurons and other cells in substantia nigra. What if I put in stem cells to regrow cells to replace the missing ones? And again, I think the results in many cases are quite fascinating, but it doesn't seem to be a panacea. So those seem to be the four major approaches, and from my perspective, none of them offer a uniform cure for everybody, and yet all four of those approaches have advocates and have some data that seems to be supported in many cases. Tempting.
How about the peripheral catechol or methyltransferase inhibitors? Are they doing any good?
I think I would have to put them sort of in that same category as L-DOPA. That is, you've got a pharmacological approach that offers some benefits, but I don't think that any of those benefits have been lasting, and they don't seem to be uniform. So in the case of L-DOPA, for example, you find that classically, if we go back 40 years, for example, and we watch patients with L-DOPA, you find that they often had good improvement initially with some side effects and some risks. And yet the benefits began to disappear over time as the disease progressed. And what little I know about pharmacologic treatment for Parkinson's suggests that that's mostly been the case throughout with all the different approaches.
So This is again a new situation in which these treatments and technologies are not having great effect because they are still continuing to focus on the symptoms and not on causes?
Well, I think that's right. It's like saying that some of these neurons are dying. So what we'll do is we'll increase the volume of the neuron, make them speak louder to the neighboring neuron. And that can have an effect. My neuron is no longer functioning, or it's beginning to die, but at least it's speaking in a louder voice to the neighboring neuron, but the neuron's still dying. So in many cases, what you see is you get some transient effects, some very promising effects, but they don't last. And it's because you're not addressing the fact that the neuron is dying. You're addressing the volume of the neuron as it speaks to the neighboring neuron. So I think that, I would make that distinction I made before between Alzheimer's and Parkinson's. In Alzheimer's, it's essentially fatal, and there is no treatment. Pretty much sums it up globally. Whereas in Parkinson's disease, it's not always fatal, it's a little harder to predict, and there are a lot of at least promising initial therapies, and a lot of interest in it. I guess I would have to say this, if these are two drugs, or two diseases, Alzheimer's and Parkinson's, and up here is a cure, where we are is sort of this. Alzheimer's, we have nothing. Parkinson's, we've got a lot of things that are so tempting, but they're not a cure. And I think what we can do in both cases is that if we understand the actual underlying causes of the diseases and treat the cause, not the effects.
What would be the hope for curing Parkinson's disease in the near future within the light of your research at Telesite?
I think very good. Our initial strategic aim is to go after Alzheimer's disease because it is fatal and there is no treatment. I think of it, people sometimes talk about going after the low-hanging fruit in a tree. And they talk about this in business, go after the low-hanging fruit. We're going after the high-hanging fruit because I think will have more impact and will make a bigger difference as we move forward. But our initial target is Alzheimer's disease. Our secondary target is basically all the other dementias, including Parkinson's disease. Also introducing vascular dementias. But then after that, our target will be to go after arterial disease and then osteoarthritis and osteoporosis and so forth. So I think that I'd have to say that Parkinson's disease is pretty much our second target. Alzheimer's is clearly the first, but whether we're going after dementias in general or Parkinson's specifically is still to be determined.
This is
good prospects, though. I think the prospects are that we should be able to demonstrate that we can prevent and cure not only Alzheimer's disease, but Parkinson's disease, and that we can do both of those things for Alzheimer's within about 24 months. For Parkinson's, give us another year or two after that. That would be what we'd hope to do. That's what we're aiming at.
Who is involved at Telesite?
Okay. There are currently 3 of us, all otherwise retired and all without salary, working full-time at Telesite. In addition, we have almost a dozen volunteer associates around the world. These include people with long careers in biotechnology, academic research, information processing, investment, law, chemistry, medicine, and other professional areas. They live in San Francisco, Boston, London, Barcelona, Indianapolis, Bethesda, New York, Detroit, Stanford, and elsewhere. They work with us because they believe, as we do, that we'll be able to entirely upend global medical care, curing age-related disease and lowering healthcare costs. They work with us because they believe, as we do, that the most effective place to start is to prevent and cure Alzheimer's disease. In addition to those of us working with us at Telesite and the 500 people who follow our quarterly updates, there are several dozen other people, far more important to all of us, who are involved with Telesite. These are the several dozen Alzheimer's patients who have asked to join our registry of volunteers for human trial. While there's no certainty about who will be able to be part of our first human trial in 2018, and no certainty we'll be able to help cure them, one thing remains quite certain. These individuals are the reason Telesite exists. We have one clear goal, to help those patients overcome Alzheimer's. These individuals and others with the same disease are the soul of our company, not because they volunteer or because they helped us to achieve success, but because they're the reason that we need to achieve success. Telesite exists because of and for patients with Alzheimer's disease.
This is very emotional, and I thank you very much. I remembered something about we talked in episode 1 when I briefly mentioned that patient suffered the autoimmune encephalitis. The book narrates Cahalan's issues with anti-NMDA receptor encephalitis and the process by which she was diagnosed with this form of encephalitis. She wakes up in a hospital with no memory of events of the previous month, during which time she would have violent episodes and delusions. Her eventual diagnosis is made more difficult by various physicians misdiagnosing her with several theories such as partying too much and schizoaffective disorder. Eventually, several physicians, including Dr. Sohail Najjar, began to suspect that Cahalan was suffering from an autoimmune disease. Dr. Najjar diagnosed Cahalan using a test that involved her drawing a clock, a test normally given to people suspected of having dementia or Alzheimer's disease. Rather than drawing the clock face normally, the disease caused Cahalan to draw all the numbers 1 through 12 on the right face of the clock, because the right side of her brain, which regulates the left side of the body, was inflamed. Najjar used this to help diagnose Cahalan and start her road to recovery. And she is now absolutely recovered and she speaks fluently with no problems, and this is an amazing recovery. She is also a journalist.
And the good news is she's better. The bad news is there are probably other patients who don't get diagnosed or get misdiagnosed. I wish it were otherwise.
Yes, and this book and the film will help many others to ask for a second opinion when no other options showed any results. Mm-hmm. Would you agree sometime in the future to come to our city, Cluj-Napoca, as speaker at a conference about these very important health problems and the amazing research at Telosite?
One, I'd be delighted to. Okay, I'd be delighted to. Second thing is, from my perspective, my priority is proving that we can actually treat, cure, and prevent Alzheimer's disease rather than talk about it. And three, it would be even more useful if I could come when I have the results in hand to say, yes, we did it, it worked. But no, I'd be delighted to. It would be a pleasure for me and an honor.
Because some university professors would find a way to sponsor this. What should they do in order to invite you for a neurology lecture?
Contact me. Again, my priority is Telosite and getting the work done and showing we can cure it. But, you know, might be happy to do it as long as it doesn't interfere with getting the work done.
Maybe somewhere after human clinical trials begins in 2018, would this be useful and more convenient for you?
Well, yes, it'd be even more useful if I could come and say, this worked, not here's why I'm pretty sure it's going to work, or I'm confident it could work, or here's the animal studies, but we did it with 12 patients and we reversed their problem.
Yes, that could be a good idea because time is already very quickly passing and 2018 is nearby. In order to complete this episode in the last minutes that remain, please tell us about mitochondrial factors in pathogenesis of various diseases.
It's another one of those things that plays a role, but people tend to get bogged down in the details. So in the same sense that you could say that beta amyloid causes Alzheimer's, it's associated, but it's not the cause. The same thing is true of mitochondria. If I look at aged cells, what you find is the mitochondrial dysfunction. But if you ask yourself, why are they dysfunctional? It turns out it's because all of the enzymes they need, the proteins they need, aren't being supplied as fast in those older cells. So, for example, if I look at the enzymes that are responsible for causing free radical damage, that is, they're responsible for aerobic metabolism, and sometimes they cause free radicals. What you find is that those enzymes aren't being supplied as quickly in an older cell because the gene expression's been turned down on the nucleus. The outcome is you've got not enough functional enzymes, so what you end up with is more free radicals. So the rate of free radical production goes up in an older mitochondria, but it's because of the telomere. And then you say, well, all right, but they're trapped in the mitochondria. They don't get out in the cell where they cause damage. And the answer is no. It turns out that the lipid membranes that prevent them from escaping, those are also being turned over more slowly, so they're more dysfunctional, and that starts back in the telomere in the nucleus. And then you say, well, all right, so they produce more and they get out more, they escape. There must be enzymes that trap them, and there are. There are scavenger enzymes that snag these free radicals. But they're also being produced not as quickly, not turned over as quickly, because the telomere is shortened. And then you say, well, all right, but they, no matter whether they produce and escape and don't get scavenged, they create a certain amount of damage, and that damage gets repaired. But the repair of the damaged molecules by free radicals also goes down with age. All four of those factors get traced back to gene expression changes that are caused by telomere shortening. And when I increase telomere length, they all get reset. So if you really want to talk about mitochondrial damage, it occurs, it goes along with aging, and it plays a role in lots of diseases. But you know what? It all gets triggered by telomere shortening. And in all cases, if I reset telomere, I reset mitochondrial function. So back to the point I raised, it's not a question of what causes it. Mitochondria play a role, but what can I fix? The answer is, I can fix that too.
But this is amazing, really amazing. So you may find a cure for these diseases caused by the mitochondrial factors, and that would be a new big step in medical science. And all we know about medicine should be rethought, books rewritten, and this changes the entire perception that we had about causes and effects. This is a big step forward.
Well, there's still cause and effect. It's just complex cause and effect. And again, my perspective is not cause and effect, but where do I step in? How do I fix it? But you're right. I think that the potential for what we're talking about doing and what I've been talking about doing now for 20 years is, one, we can probably cure almost all age-related diseases. Not all diseases, but probably all age-related diseases. Diseases that we previously have felt that you can't really cure or fix. Maybe you can put Band-Aids on them, but you can't fix them. No, I think we can fix them and prevent them. And the second thing is, as opposed to many medical advances, like robotic surgery and heart transplants and a lot of new statins, whatever the drug you pick, they tend to increase the cost of medical care. I don't think that's the case here. I think we can actually lower the cost of global medical care. Globally, by country, by state, by city, by individual, you pick the level. What I think we're going to be able to do is not only cure diseases that we never really could cure before and prevent them, most age-related diseases, but do so at a fraction of the current cost.
Did you hear about an unusual research which is about to be performed in December 2017, a first human head transplant? I am quoting from this article. Earlier this year, Italian neuroscientist Sergio Canavero shocked the world when he announced he would perform the world's first human head transplant. Canavero announced the procedure is scheduled for December 2017, and he has recruited a head surgeon to lead the controversial procedure. This operation may sound like something out of a horror movie, but one man is hoping it will improve his quality of life. A 30-year-old Russian man, Valery Spiridonov, volunteered for the procedure in the hope of living a more normal life. The computer scientist suffers from a rare motor neuron disease known as Wernicke-Hoffmann disease. The disease causes motor neurons, the nerve cells responsible for sending signals from the central nervous system to your muscles, to deteriorate, which leads to muscle atrophy and, in severe cases, difficulty swallowing and breathing. Currently, there is no treatment for this disease.
Well, I wish them luck. I have an appreciation for the complexity and the risk of that. And I would guess that, one, it won't be anywhere near as effective as we'd all wish. And two, that the expense of that, not to minimize the man's life, but the expense of that is enormous.
I thank you greatly for part 3 of our amazing interview analyzing these 4 age-related diseases and let's meet next time for part 4 about atherosclerosis in our Science and Knowledge TV program on TVR Cluj, Romania. And I thank you very much for this opportunity.
Very good.
Cred că știința are deja la îndemână instrumentele teoretice și practice pentru a ne ajuta să eradicăm majoritatea maladiilor degenerative și a celor legate de îmbătrânire. Dar aceste terapii nu își vor putea dovedi eficiența fără o modificare profundă a stilului de viață pentru a atinge acel grad de civilizare despre care amintea profesorul Fossel. Știința, de fapt, este cel mai bine definită ca o căutare atentă, disciplinată, logică, de cunoștințe despre toate aspectele Universului, obținute prin examinarea celor mai bune dovezi disponibile și este întotdeauna supusă unor operațiuni de corecție și îmbunătățire pe baza descoperirii unor dovezi mai bune. Fiți alături de noi data viitoare la o nouă întâlnire cu știință și cunoaștere.